In our previous lecture, we built the basic physiology of pulmonary gas exchange, how oxygen enters the blood, how carbon dioxide is removed, and how factors such as ventilation, VQ matching, and FiO₂ determine PaO₂ and PaCO₂. Now that we understand what normal gas exchange should look like, the next logical question is, what happens when this system does not work properly? But before we continue, there is one important concept from our previous discussion that we need to complete. We briefly discussed the oxyhaemoglobin dissociation curve, but we did not yet explain what happens when this curve shifts to the left or to the right. So, before moving forward, let's quickly understand left and right shifts of the oxyhaemoglobin dissociation curve. In the previous lecture, we learned that PaO₂ and SaO₂ are related, but the relationship is not linear. As PaO₂ falls, SaO₂ does not always fall by the same amount. Once we move into the steep part of the oxyhaemoglobin dissociation curve, even a small fall in PaO₂ can cause a much larger fall in SaO₂. But there is one more important concept we need to understand before we move forward. Now look at this curve. The horizontal axis represents PaO₂, or the partial pressure of oxygen in arterial blood, and the vertical axis represents SaO₂, or the percentage of hemoglobin that is saturated with oxygen. Normally, as PaO₂ increases, more oxygen binds to hemoglobin, so SaO₂ increases. But sometimes hemoglobin changes how strongly it holds oxygen, and this causes the whole curve to shift. If the curve shifts to the right, it means that for the same PaO₂, hemoglobin has a lower SaO₂ than before. In other words, hemoglobin is holding oxygen less tightly, so it releases oxygen more easily to the tissues. You can also look at it from the opposite direction. If we want to achieve the same SaO₂, we now need a higher PaO₂. So a right shift means lower SaO₂ at a given PaO₂, or a higher PaO₂ is required to achieve the same SaO₂. On the other hand, when the curve shifts to the left, it represents at the same PaO₂, SaO₂ will be higher, that is, hemoglobin holds oxygen more tightly, and the same SaO₂ can be achieved at a lower PaO₂. So, remember the simplest relationship: right shift, hemoglobin holds oxygen less tightly, and oxygen is released more easily to tissues. Left shift, hemoglobin holds oxygen more tightly, and therefore oxygen is released less easily to tissues. Importantly, the shift itself does not necessarily mean that the patient's PaO₂ has changed. Instead, it changes how much oxygen hemoglobin binds at a given PaO₂. Now, after understanding the graphical shift of the curve, let's step back and see what is actually happening inside the body. First, remember that oxygen in the blood is present in two forms. A very small amount of oxygen is freely dissolved in the plasma, and the much larger amount of oxygen is attached to hemoglobin inside the red blood cells. And this is what allows the blood to carry a large amount of oxygen. So PaO₂ tells us about the oxygen freely dissolved in the blood, while SaO₂ tells us about the oxygen attached to hemoglobin. Now the important thing is that hemoglobin does not always hold oxygen with exactly the same strength. We call this its affinity for oxygen. So hemoglobin does not always have the same affinity for oxygen. Its affinity can change depending on the conditions around it, especially pH and carbon dioxide. For example, when the tissues are working hard, they produce more carbon dioxide. When carbon dioxide increases, it reacts with water and ultimately increases hydrogen ions, which causing the pH to fall, and the temperature of the tissues may also increase. These hydrogen ions interact with hemoglobin and make hemoglobin hold oxygen less tightly. This is called the Bohr effect. Under these conditions, hemoglobin's affinity for oxygen decreases, so it holds oxygen less tightly and releases more oxygen to the tissues. So, here PaO₂, that is free oxygen dissolved in the blood, remain the same. But hemoglobin now releases more oxygen, meaning the SaO₂ becomes lower. In other words, the oxygen that was attached to hemoglobin is being released even though the PaO₂ may initially be the same. And this is exactly what we see on the oxyhemoglobin dissociation curve. That is, at the same PaO₂, the SaO₂ becomes lower, and as a result, the curve shifts toward the right. Again, this tells us that hemoglobin is holding oxygen less tightly and is therefore releasing more oxygen to the tissues. Now let's look at the opposite situation. What happens when carbon dioxide decreases, the pH increases, or the temperature decreases? In this situation, hemoglobin's affinity for oxygen increases. In other words, hemoglobin becomes more willing to hold on to oxygen and less willing to release it to the tissues. So, hemoglobin binds more oxygen and holds onto it more tightly. As hemoglobin takes up more oxygen is removed from the freely dissolved pool in the plasma. So the PaO₂ may tend to fall back toward equilibrium, while the amount of oxygen attached to hemoglobin increases, causing the SaO₂ to increase. And this is exactly what we see on the oxyhemoglobin dissociation curve. As hemoglobin's affinity for oxygen increases, the SaO₂ becomes higher at a given PaO₂, and the curve shifts toward the left. Again, this tells us that hemoglobin is holding oxygen more tightly and is therefore releasing less oxygen to the tissues. I hope now this makes sense. After completing the left and right shift of the oxyhemoglobin dissociation curve, let's continue with today's discussion. In this lecture, we will move from normal physiology to the disorders of gas exchange. We will see how problems in the lungs can disturb oxygenation and ventilation, and how these disturbances appear on an ABG. We will particularly focus on the two major patterns: when PaO₂ falls because of an oxygenation problem, and when PaCO₂ rises because of inadequate ventilation. We will then learn how to recognize these patterns on the ABG and understand what they mean clinically. Now that we understand that disorders of gas exchange can interfere with oxygen delivery, we need to make one important distinction between three terms that are often used interchangeably: hypoxia, hypoxemia, and impaired oxygenation. They are related, but they are not the same thing. Let's start with the simplest one: hypoxia. Hypoxia means that the tissues are not receiving enough oxygen to meet their needs. Hypoxemia simply means that the oxygen content of arterial blood is reduced. Impaired oxygenation specifically means that the lungs are not transferring enough oxygen from the alveoli into the bloodstream. So, these three concepts are connected in a sequence. Impaired oxygenation means that the lungs are not transferring enough oxygen from the alveoli into the blood. This can reduce the oxygen content of arterial blood, resulting in hypoxemia. If the reduction in oxygen in the blood is severe enough, or if oxygen delivery to the tissues is inadequate for another reason, the tissues may not receive enough oxygen to meet their metabolic needs, resulting in hypoxia. So, in a simple way, we can think of it as impaired oxygenation can result in hypoxemia and potentially hypoxia. Hypoxia can also develop if the blood supply to the tissue is inadequate, which we called ischemia. When tissues do not receive enough oxygen, they may switch from aerobic metabolism to anaerobic metabolism and produce more lactic acid. Hypoxemia can happen for several reasons. One reason we have already discussed is that the lungs may not transfer enough oxygen from the alveoli into the blood. In addition, hypoxemia can also occur when the patient has a low hemoglobin concentration, as in anemia, because there is less hemoglobin available to carry oxygen. Another possibility is that the hemoglobin itself may not be able to carry oxygen normally, for example in carbon monoxide poisoning. As carbon monoxide has about 200 times greater affinity for hemoglobin than oxygen, so it binds very strongly to hemoglobin and occupies the oxygen binding sites. As a result, less hemoglobin is available to carry oxygen, and the hemoglobin that has bound carbon monoxide also holds onto its remaining oxygen more tightly, making oxygen unloading to the tissues more difficult. Therefore, the total oxygen carrying capacity of the blood decreases, which can lead to tissue hypoxia. Now, an important point for ABG interpretation is that the PaO₂ can remain normal in carbon monoxide poisoning because PaO₂ measures the oxygen freely dissolved in plasma, not the oxygen attached to hemoglobin. Therefore, a patient with carbon monoxide poisoning can have a normal PaO₂ despite having significant tissue hypoxia. Similarly, the oxygen saturation reading can be misleading. A standard pulse oximeter cannot reliably distinguish between hemoglobin carrying oxygen and hemoglobin bound to carbon monoxide, so the peripheral oxygen saturation may appear normal. Therefore, a patient can have a normal PaO₂ and an apparently reassuring oxygen saturation while still having significant impairment of oxygen delivery to the tissues. As impaired oxygenation means that the lungs are not transferring enough oxygen from the alveoli into the bloodstream. On an ABG, we identify this by looking at the PaO₂. A PaO₂ below about 80 millimeters of mercury indicates impaired oxygenation. But here is an important point. Impaired oxygenation does not automatically mean that the tissues are already hypoxic. For example, imagine a patient has a PaO₂ of 65 millimeters of mercury. This tells us that oxygen transfer from the lungs is impaired, but the hemoglobin may still be more than 90% saturated, and if hemoglobin concentration and cardiac output are adequate, the tissues may still receive enough oxygen. So, we should not immediately equate a low PaO₂ with tissue hypoxia. So, a PaO₂ value by itself does not tell us whether the tissues are receiving enough oxygen. A PaO₂ of 65 millimeters of mercury tells us that oxygenation is impaired, but the oxygen saturation may still be above 90%, so the patient is not necessarily tissue hypoxic. On the other hand, in carbon monoxide poisoning, the PaO₂ may be completely normal, yet oxygen delivery to the tissues can be severely impaired because hemoglobin is not carrying oxygen normally. So the key message here is PaO₂ gives us an idea of how effectively the lungs are transferring oxygen from the alveoli into the blood, but it does not by itself tell us whether the tissues are receiving enough oxygen. So impaired oxygenation means the lungs are having difficulty getting oxygen into the blood. Hypoxemia means the oxygen content of arterial blood is reduced, and hypoxia means the tissues are not receiving enough oxygen. Now that we understand the difference between impaired oxygenation, hypoxemia, and hypoxia, let's move one step further and look at a very common pattern of gas exchange abnormality. That is type 1 respiratory impairment. The simplest way to understand type 1 is to remember that the main problem is oxygenation, not ventilation. In other words, the lungs are having difficulty getting enough oxygen into the blood, so the PaO₂ becomes low, while the PaCO₂ is usually normal or even low. This tells us that the patient is still ventilating adequately and is able to remove CO₂, but oxygen is not being transferred effectively from the alveoli into the blood. So, why does this happen? The usual mechanism for this is ventilation perfusion or VQ mismatch. For example, conditions such as pneumonia, pulmonary embolism, pneumothorax, pulmonary edema, acute asthma, ARDS, fibrosing alveolitis, and chronic obstructive pulmonary disease can interfere with normal oxygenation. In some conditions, such as alveolitis, the problem may instead involve impaired diffusion across the alveolar capillary membrane. But regardless of the exact cause, the important result is the same. Less oxygen reaches the arterial blood, so PaO₂ falls. Now you may notice something interesting. If oxygenation is impaired, why doesn't PaCO₂ also rise? We actually discussed the answer to this in our previous lecture when we talked about VQ mismatch. But let's quickly revisit it here because it is very important for understanding type 1 respiratory impairment. Remember our example of 10 alveoli. Normally, all 10 alveoli are receiving air and blood, so oxygen can enter the blood and carbon dioxide can leave the blood normally. Therefore, both PaO₂ and PaCO₂ remain within their normal ranges. Now suppose 3 of these 10 alveoli become filled with fluid or collapse. But blood can still flow through these 3 affected alveoli, but very little or no fresh air reaches them. As a result, the blood passing through these alveoli cannot pick up enough oxygen and cannot remove carbon dioxide effectively. So, this blood leaves the affected area with low oxygen and more carbon dioxide. But we still have 7 healthy alveoli. Because some alveoli are no longer functioning properly, more of the air we breathe is directed toward these remaining open healthy alveoli. These healthy alveoli can therefore increase their ventilation. Now when these healthy alveoli receive more fresh air, they can remove extra carbon dioxide from the blood very effectively. In this way, the healthy alveoli can compensate for the extra carbon dioxide coming from the poorly ventilated alveoli. As a result, the overall PaCO₂ can remain normal provided that overall alveolar ventilation is maintained. But oxygen is different. Because of increased ventilation, these healthy alveoli receive more fresh oxygen-rich air. So the blood passing through them picks up oxygen and hemoglobin becomes almost completely saturated, usually above 95%. So even if we give these healthy alveoli even more air, they cannot put much more oxygen onto hemoglobin, as the buses are already almost full. Therefore, they cannot compensate for the poorly oxygenated blood coming from the affected alveoli. When the poorly oxygenated blood mixes with the normally oxygenated blood, the overall PaO₂ and SaO₂ fall. So, the important point to remember is ventilation-perfusion mismatch mainly causes a problem with oxygenation, that is, PaO₂ falls, while PaCO₂ can remain normal if overall alveolar ventilation is maintained. Clinically, this is important because it explains why a patient can have significant lung disease and a low PaO₂ even when their PaCO₂ is still normal. So, when you see this pattern on an ABG, think, the patient may have an oxygenation problem due to ventilation-perfusion mismatch, even though ventilation, judged by PaCO₂, is still being maintained. Another important point we discussed earlier is that when a patient is receiving supplemental oxygen, we cannot interpret the PaO₂ simply by asking whether it is above 80 millimeters of mercury. We also need to consider how much oxygen the patient was receiving when the ABG was taken. This is another important point that we discussed in our previous lecture when we talked about FiO₂. Remember, when we look at a PaO₂ value, we should not interpret it in isolation. We also need to know how much oxygen the patient was breathing when the ABG was taken. Let's go back to the simple example we used earlier. Imagine patient A is breathing normal room air, which contains about 21% oxygen, and the ABG shows a PaO₂ of 80 millimeters of mercury. Since the normal PaO₂ is roughly 80 to 100 millimeters of mercury, this value would be reasonably reassuring. Now consider patient B. Suppose patient B is already receiving supplemental oxygen, meaning the patient is breathing a higher FiO₂ than room air, but the PaO₂ is still only 80 millimeters of mercury. At first glance, both patients have the same PaO₂, but the meaning is very different. For patient A, the lungs achieved a PaO₂ of 80 millimeters of mercury while breathing normal room air. But for patient B, the lungs achieved only the same PaO₂ despite receiving additional oxygen. This suggests that oxygenation is more severely impaired in patient B because we expect PaO₂ more than 80 millimeters of mercury when we are receiving supplement oxygen. So whenever you see a PaO₂ on an ABG, always ask one simple question. How much oxygen was the patient receiving when this ABG was taken? In other words, we should always interpret the PaO₂ in relation to the FiO₂. Now, how do we judge how severe this type 1 respiratory impairment is? This is where the oxyhaemoglobin dissociation curve that we discussed earlier becomes very useful. If the PaO₂ falls from the normal range down toward about 60 millimeters of mercury, the SaO₂ does not fall dramatically because we are still relatively close to the flatter portion of the curve. However, once PaO₂ falls below this range, we move into the steep portion of the curve. From this point onward, even a small further fall in PaO₂ can produce a much larger fall in SaO₂, causing a significant reduction in the oxygen content of arterial blood. Therefore, we classify type 1 respiratory impairment as mild when PaO₂ is about 60 to 79 millimeters of mercury with SaO₂ 90-94%, moderate when PaO₂ is 40 to 59 millimeters of mercury with SaO₂ 75-89%, and severe when PaO₂ is below 40 millimeters of mercury with SaO₂ below 75%. Finally, the clinical importance is that we are not only interested in the number on the ABG, we want to know whether the patient is receiving enough oxygen. Therefore, the initial treatment is aimed at improving oxygenation, usually with supplemental oxygen, while at the same time treating the underlying cause of the respiratory impairment. As the patient's condition improves, pulse oximetry can often be used to monitor oxygenation instead of repeatedly performing ABGs. And in severe cases, we become particularly concerned when hypoxemia progresses to tissue hypoxia, which may present with features such as lactic acidosis, confusion, renal dysfunction, hemodynamic collapse, or coma. So, if you want to remember type 1 respiratory impairment in one simple line, type 1 respiratory impairment means that the main problem is oxygenation. In this condition, the PaO₂ falls, while the PaCO₂ usually remains normal or may even fall. This is most commonly due to a VQ mismatch. Treatment is therefore aimed at improving oxygenation with supplemental oxygen while also treating the underlying cause. Now that we have understood type 1 respiratory impairment, where the main problem is oxygenation, let's move to type 2 respiratory impairment. Here, the main problem is different. The patient is not ventilating adequately. In simple words, the patient is not bringing enough fresh air into the alveoli and therefore is unable to blow off the carbon dioxide produced by the body. As a result, carbon dioxide starts accumulating in the blood, so the PaCO₂ rises. This high PaCO₂ is called hypercapnia. Because ventilation also contributes to oxygenation, the PaO₂ will usually fall as well, although it may appear normal if the patient is receiving supplemental oxygen. So, the simplest way to recognize type 2 respiratory impairment is the main abnormality is a high PaCO₂ due to inadequate alveolar ventilation. Now, what can cause this inadequate ventilation? There are several possibilities. For example, a patient may simply become exhausted after prolonged respiratory distress, so the respiratory muscles can no longer maintain adequate ventilation. In addition, flail chest injury, kyphoscoliosis, neuromuscular disorders, or an inhaled foreign body can interfere with effective breathing. Drugs such as opioids or benzodiazepines can also depress the respiratory drive. Similarly, obstructive sleep apnea can cause inadequate ventilation. Chronic obstructive pulmonary disease can also produce type 2 respiratory impairment, although COPD can lead to either type 1 or type 2 impairment depending on the situation. Now there is another important point. What happens when PaCO₂ rises? Remember from our earlier discussion that carbon dioxide combines with water and contributes to the formation of hydrogen ions. Therefore, when PaCO₂ rises suddenly, acid begins to accumulate in the blood and the pH falls. This is particularly dangerous when the rise in PaCO₂ is acute. However, if the patient has had a high PaCO₂ for a long time, the kidneys have time to compensate by retaining more bicarbonate. Therefore, in chronic type 2 respiratory impairment, PaCO₂ is high, but bicarbonates also increases, helping to bring the pH closer to normal. Now, if the PaCO₂ rises suddenly, the body does not have enough time to compensate. The extra carbon dioxide quickly leads to an increase in hydrogen ions, so acid accumulates in the blood and the pH falls. Because the kidneys need time to respond, the bicarbonates level does not increase significantly at first. Therefore, in acute hypocapnia, we see rise in PaCO₂, low pH, with little or no initial increase in bicarbonates. But now imagine a patient who already has chronic hypercapnia and then suddenly becomes worse. For example, their ventilation decreases even further. In this situation, PaCO₂ rises rapidly on top of the already elevated baseline. This is called acute-on-chronic type 2 respiratory impairment. Because the carbon dioxide rises faster than the kidneys can compensate, the pH falls, indicating acute respiratory acidosis. So, in acute type 2 impairment, PaCO₂ rises, bicarbonate has not yet increased significantly, and pH falls. In chronic impairment, both PaCO₂ and bicarbonates are elevated and the pH may be close to normal. While in acute on chronic impairment, both PaCO₂ and bicarbs are elevated. But the sudden additional rise in PaCO₂ causes the pH to fall again. Now, this also explains an important treatment principle. Giving supplemental oxygen can improve the low PaO₂, but it does not correct the underlying problem of inadequate ventilation. In other words, oxygen can put more oxygen into the blood, but it does not necessarily help the patient remove the accumulated carbon dioxide because of inadequate ventilation. Therefore, in type 2 respiratory impairment, we need to address ventilation as well. For example, by reversing respiratory depression, relieving airway obstruction, or providing assisted ventilation when necessary. The excessive oxygen administration in these cases can worsen ventilation in some patients with chronic type 2 impairment because of hypoxic drive, which we discussed earlier in part 1. Finally, this is why ABG becomes particularly important in type 2 respiratory impairment. Pulse oximetry can tell us about oxygen saturation, but it cannot tell us what is happening to PaCO₂. A patient may have an acceptable peripheral oxygen saturation, while carbon dioxide continues to accumulate. Therefore, unlike type 1 impairment, where pulse oximetry can often be useful for monitoring oxygenation, in type 2 respiratory impairment, we need the ABG to assess the patient's ventilation and PaCO₂. So, the simplest way to remember the difference is, type 1 respiratory impairment is mainly an oxygenation problem. The PaO₂ falls, while the PaCO₂ usually remains normal or may even decrease. In contrast, type 2 respiratory impairment is mainly a ventilation problem. The PaCO₂ rises because the patient is not adequately removing carbon dioxide, and the PaO₂ usually falls as well. And for type 2, always remember, supplement oxygen may correct the low oxygen, but it does not blow off the carbon dioxide, so the ventilation problem must also be corrected. Now, after discussing inadequate ventilation in type 2 respiratory impairment, let's now move to the opposite situation and discuss hyperventilation. Hyperventilation simply means that the patient is breathing more than the body actually needs. In other words, the rate and/or depth of breathing increases, so the patient removes more carbon dioxide from the body than normal. As a result, the PaCO₂ falls. And because carbon dioxide contributes to the formation of acid in the blood, a fall in carbon dioxide causes the blood pH to rise, producing respiratory alkalosis. Now, you may notice that the patient is breathing faster or deeper. But the important point is to understand what is happening to the gases. Because the patient is breathing more carbon dioxide is being removed from the body, so PaCO₂ decreases. However, the PaO₂ is usually normal because oxygenation is not necessarily the problem. This is an important ABG pattern. Low PaCO₂ with a normal PaO₂ suggests that the patient is hyperventilating rather than simply having a primary oxygenation problem. Now, what can cause hyperventilation? There are several possibilities. For example, anxiety or psychological distress can cause a person to breathe rapidly even though the lungs themselves may be normal. Pain and fever can also increase breathing. Similarly, hypoxemia can stimulate breathing because the body tries to increase ventilation in response to low oxygen. Certain conditions such as salicylate toxicity, liver cirrhosis, and some central nervous system disorders can also cause hyperventilation. However, there is another important situation. Sometimes hyperventilation is not the primary problem, but is actually the body's compensation for another problem. For example, in metabolic acidosis, the body increases ventilation to remove more carbon dioxide and thereby helps bring the pH back toward normal. This is called secondary or compensatory hyperventilation. Now, there is one more interesting clinical point. If hyperventilation causes a large fall in PaCO₂, the patient may develop tingling around the mouth or in the hands and feet, lightheadedness, and in severe cases, even fainting. This is why a patient with anxiety-related hyperventilation may look quite distressed and complain, "I can't get enough air," even though their oxygen level may actually be normal. The ABG can help us recognize this pattern by showing a low PaCO₂ with a normal PaO₂. So, the simplest way to remember hyperventilation is the patient is breathing too much for their metabolic needs, more carbon dioxide is blown off, PaCO₂ falls, blood pH rises. And importantly, hyperventilation does not necessarily mean that the patient has a problem getting oxygen into the blood. The main ABG abnormality is the low PaCO₂. Therefore, the treatment of hyperventilation depends on its underlying cause. We should not simply slow down the patient's breathing. Instead, we need to identify and treat the reason why the patient is hyperventilating.